relatable, reliable, real information about breast cancer to all our Pink Sisters to give some support during COVID and beyond. And so we got an exciting show tonight, and I got to reunite with an old friend and colleague, and some amazing collaborations are going to happen, and we'll talk about everything. But Ricky, do you want to introduce our guest tonight?
I would love to. So we have Dr. Lori Wilson, who is a doc, a breastie, and a teacher. So today, I'm sure she did all of those things, right? And
yeah,
so
I did.
we talk about that. She's a badass. She's the chief oncologist at Howard University Hospital, and guess that got pretty popular today with our new vice president candidate, right?
Exactly.
I know.
See, I got a shirt. There it is. Had to represent.
Yep. And so we have lots to share, and we love you, Dr. Lori. I can't wait for you to tell your story. And then my breastie, Marquita Bass, who I met, I guess, almost a year ago at LBC conference, right? And she actually wrote a book called Orange is the New Pink. And when I met her, she came up to me and said, "Your name is Ricky Fairley." I'm like, "Yeah, that's my name." And she said, "I quoted you in my book." And I'm like, "What book?" And so I didn't even know her. So I was pretty, so you quoted me? What do I know? But it was great to connect with her. And so let's go. So let's talk about triple negative. What is it?
All righty. So we always like to give a little bit of background before we start. And for those of you who are watching who maybe don't understand that there are different types of breast cancer, and the types of breast cancer can be classified by where it started. So did it start in the ducts or the tubes that carry the milk, or did it start in the lobules or places where milk is produced? We talk about things like hormone receptors, or the places on the tumor that receive the signals to grow and to change and to what we call proliferate, or to metastasize or go somewhere else outside of the breast. So these receptors, the easiest way I think to understand them, and I tell patients, I use a lot of analogies that are basic, but they're like toll booths on the turnpike, right? Toll booths on the PA turnpike. So if you have the toll booth, then we can try to intercept the signal or the dollars or the money that is getting to that toll. And this is the basis for how things like tamoxifen work. And some of you have heard of pills like tamoxifen or anastrozole or letrozole, things that block estrogen. So those are oral pills that take away the dollars so that you can't go through any additional tolls. There are other medicines that target different tolls, like the HER2 receptor. When women don't have those receptors, I tell patients it's like being in the easy pass lane. I could give you a pill and take away your dollars, but you're not using dollars. Your signal is working from another mechanism. And so women who don't have those tolls or those signals on the cancer cell, those receptors, those stations, are considered to have triple negative breast cancer because they're negative for the estrogen receptor, the progesterone receptor, and that HER2 receptor. And if you're watching and you are recently diagnosed or you're a survivor, this is kind of an important thing that you want to know and be able to share with your children. It impacts your treatment, and it impacts your potential hereditary component as well. So Dr. Lori, did I give a good explanation of that?
I love your explanation. I think it's key to know that there are not just a word breast cancer, that you have to break it down. It's like saying soup. When you say soup, you know that there's going to be bean soup, there's going to be vegetable soup. So when we think about cancers, we know that there are different types of cancers, and then breaking it down to where they start. I love that. And then ultimately coming up with a picture that helps us to understand that when we talk about breast cancer and the cell actually has those 3 markers on them, or 3 locks that are important. And estrogen receptor, progesterone receptor, and HER2, they're all on the cell. And whether they're present or not is very important, because if they're present, then it says something about the way we should treat you. We have to understand that we no longer treat things as cookie cutter. Everything is tailored to what you bring in the door. So you may have a friend say, that's not the way I did it, or how they did my treatment, but it's because we've broken it down to knowing exactly what your cells are saying to us. And then we know what medications and what treatments are going to take care of that. So
I love that you said that because, you know, I watched my grandmother had breast cancer not once, but twice. And when I look at what happened to her, every woman at that time in the 80s got surgery. They all got chemo. They all got radiation. They all got everything, you know, and now I'll see patients who also have had family members with cancer and they say, but that's not the way my mother was treated. That's not the way my sister was treated. And so understanding this is really important. And it sounds like a basic thing, but it determines how you are able to participate in clinical trials. It determines the types of medicine that you'll receive. It determines your whole body therapy. So knowing your hormone receptor status is very important. And Dr. Lori, I'm gonna ask you later about why and how they change, because that is an important point, especially for Black women. When we find that our disease recurs, what happens there and why might those receptors change? And should we be aware of that? Because sometimes the doctors aren't always aware. We're treating for one thing, and we might have something different. So we'll get to that point. But Ricky, go ahead. You had some statistics for us about—
I had something, being a patient. So,
Mhm.
you know, so I was diagnosed in 2011. And back then, when you Googled triple negative, basically it said you're going to die. There were probably only like 3 citations on Google, and they all were pretty devastating. I think the science has come a long way, even in the past 10 years, about triple negative, because it really had just been named not too long after I was diagnosed, right? But the one thing that I was always told and concerned about, well, you know, it's more aggressive, it's the most aggressive, it has the highest mortality rate, and it's the only breast cancer that doesn't have a drug to prevent recurrence. So something like a tamoxifen or something that you take for 5 years, we don't have a drug for triple negative. My drug is paddleboarding and God, right? So, but you know, and the recurrence rate is pretty aggressive and fast. And frankly, my doc, and we can talk about this later, but my doc, she was 38, she was very young. She had only had 2 cases of triple negative before me, and both of the women died in 9 months. So I said to her, well, you know, we need to go get some help because I don't know what I'm talking about, and I don't think you do either. But so I think we should talk about that. But I think it's come a long way, and it's not as scary as it has to be, but it is very aggressive. And we know that Black women get triple negative at 2.3 times the rate. And I don't have exact numbers for Black women under 40, but I would think it's at least 3 to 4 times the rate. So it is definitely one of our Black breast cancers that we always talk about, you know, in this Black breast cancer category, and it's affecting us. And our mortality rate is significantly higher for triple negative than white women. So it's something that we all need to know about and talk about. I think also I was offered gene testing, which not everybody is, and I don't have any gene mutations, as we've talked before many times, but triple negative is often associated with the breast cancer gene. And I think that's more prevalent even in my case. Do you think so, guys? Or
And I think that one of the key things is to know what type of gene testing was done.
right?
Because definite differences in the number of genes that can be tested. I think early on, BRCA was the only gene that was tested, and now there's 80, 90, 100 plus genes that can be tested. And it's important to ask and to know, what did your team choose for you and why?
Right. And Dr. Regina did my testing, you know, and so I think whatever I had, like the biggest panel, you know, but even when she called me with the results, she said, well, you don't have any mutations. I said, well, that's good, right? She's like, Ricky, I don't have a clue. Like it really, I mean, we don't know, because there could be something that we don't know about yet, that we haven't checked, and we don't have that science.
The other thing to think about is, you know, we did a show maybe about a month ago, Ricky, where we talked about genetic testing, hereditary versus somatic testing. So testing of your genes, what you're born with, what you inherit from mom and dad, versus testing of your tumor. Those are different concepts also. We need to put a glossary together on the website on Touch, because when we talk about genetic testing, it gets a little bit murky and confusing for patients. You know, you're just wrapping your head around this diagnosis, and then we're talking about testing your genes, and that is an important thing, but testing the genes that you were born with, hereditary, versus testing the genes inside your tumor, which is something else. So germline versus somatic. And so
I didn't know those would be different. Wow.
They are absolutely different. So we talk about the BRCA mutation, you know, we associate that with hereditary cancer, but you can have a mutation in your tumor as well that you did not inherit from your parents, because we know that tumors, a cancer cell, you know, an easy way to explain this for those who are over the age of 40 probably, is I love Lucy, and I love this analogy, but she and Ethel work in a chocolate factory, and the chocolates just keep coming off the belt, and they're making, you know, the machine's gone haywire, and all of a sudden, that's what cancer is. The cells grow and grow and grow until you've got a tumor. But not all the factory mistakes are passed down generation after generation after generation. That's heredity.
Right.
And when patients get that light bulb goes off, we can test you to see if you inherited a change in your genes, but we can also test your tumor to see what genes changed in your tumor.
Oh, that's pretty cool. We need to talk about that some more, Mo, you know?
Yeah, we could do it.
Yep.
And I think that,
Oh, go ahead.
no, I was about to say that is exactly the difference in the tumors that I had. That when they tested my tumor, I had a somatic change in BRCA. So I was BRCA positive when they looked at my tumor. And that's not something that is typically done in all patients. And then I had the gene testing, which is just a swab, which looks at my hereditary aspect. And so that was actually a gene of undetermined sort of significance. So do we know? There's still lots out there to hopefully learn about our genes, but it's important for us to know the difference and to ask the questions of our team. Is it important for me, and should I have it done for me?
Right. And how would we know that as a patient? You know, I mean, I didn't know anything about this when I got sick, you know, so that's why, you know, we have to keep talking about it and educating people, because we don't even know what to ask. So this is all great learning. So Marquita, tell us your story.
Sure. I want to talk about the genetic testing. Actually, when I was diagnosed in 2012, I participated in a study by the University of Washington, and they tested a lot of genes. And actually, I think that was hereditary. And actually, my doctor recently, my breast surgeon, repeated that test because she said since 2012, there's been different mutations in the BRCA. I'm not a doctor, but I'm just saying, you know, and so she repeated my test actually 3 weeks ago. So I think it depends on where you are, and the facility where you're being treated may impact whether or not the type of genetic testing that you get. But Ricky, thank you for having me on. Guys, my name is Marquita Bass, and I am an 8-year triple negative breast cancer.
Yay.
And, you know, for the individuals who are listening, who recently been diagnosed, who've gone through treatment, or who out of treatment, I just want to encourage you and empower you and let you know that although it's hard, you can get through it. And my aunt actually died within a month after I was treated for triple negative at the same time. I mean, her tumor was smaller than my tumor. And I think we talked earlier about, you know, although it was triple negative, my doctor said she may not have had the same subtype of triple negative. So I'm here, and I want to encourage women.
Yes, we're here.
You can get through triple negative. And it's very difficult. I mean, there were times when I was like, Lord, I can't do this, but you get through it. And I'm 8 years out, I'm healthy. And now during COVID, I'm just trying to figure out how I can meet a boyfriend. So, you know, and I say that jokingly, but it's serious to let you know that it improves. For women if you've listened and you've never been diagnosed, you know, I want to encourage women to monitor and manage your breast cancer risk factors from a standpoint. You know, talk to your doctors about your risk factors and manage those risk factors. I participated in a webinar recently, and Dr. Lisa Newman was on the webinar. And she's done a lot in the breast cancer space with BRCA and everything. And she said something that was very interesting. She said 30% of cancers, now I don't know if she meant breast cancers, but my point is she said 30% of cancers may be avoidable. And I don't know if that was just breast cancer or cancer in general, but the point was she was talking about risk factors. And more women need to manage their risk factors. And, you know, since my aunt died from breast cancer, from triple negative, and I'm here, I was encouraged. I felt inclined to write a book from a patient standpoint on breast cancer. And in my book, Orange is the New Pink, for triple negative breast cancer, You know, I talk about my journey. I talk about the things that women don't want to talk about, the heartache. I talk about laughter. I talk about sex, body image, sadness that we may go through. You know, before I went into surgery and I realized I was going to lose my breast, the first thing I thought about was how sex was. And women typically don't talk about those type of things. And I just want to share that to say it's normal and you get through it. And most women survive triple negative. I know a lot of women have recurrent, but I think most women survive. And I just want to encourage you to advocate for your health. Ask your doctors a lot of questions. And I, you know, just from talking, I mean, listening to these two doctors on the panel, I'm just encouraged.
Right.
Ask your doctors a lot of a lot of questions, and just know that you can get through it. It's going to be difficult, but you can get through triple negative. And it doesn't have to be a death sentence. And everybody's experience is different. Everybody's experience is different. But, you know, that's all I want to say. You know, I wrote a book for women who've never had breast cancer because also I don't want to meet another female who can't tell me what type of cancer she had. Consequently, in chapter 1 of my book, I talk about from a patient standpoint, and I have my references, what are the different types of breast cancer? Because as you guys have, you know, indicated, that drives your treatment. And also, if you know, most cancer is hormone positive, maybe you can do things early on to not do things to disrupt your endocrine system. But just be encouraged. And I'm an 8-year survivor, and you can survive triple negative breast cancer. Thank you.
Awesome.
Absolutely.
That's awesome. Yeah.
And I love that you said that, because, you know, one of the things that is so hard for patients to hear when they first get diagnosed with, especially with triple negative breast cancer, is that the only medicine we can give you is a medicine that targets all the fastest growing cells in your body, which is chemotherapy, because it doesn't have that estrogen receptor. And then you go online and you read that triple negative breast cancer has a 77% survival at 5 years compared to all the estrogen receptor, the hormone receptor positive, which the survival is 93%.
Right.
But, you know, there is some good news in that once you get past that 5-year mark for triple negative breast cancer, that risk of recurrence does drop down. And there's a window there. There's a room for intervention, for prevention, for improving your lifestyle. You know, Dr. Newman was talking about, you know, risk factors for cancer. We know that probably more than 30% of cancers can be prevented through lifestyle modification. That's probably all cancers, not just breast, but a good bit of what happens to us has to do with our lifestyle. And you know, for Black women, a good bit of it doesn't. And there's this black box of factors that we need to really try to open up so that we can understand why we develop breast cancer, particularly, you know, at a more aggressive rate, not a higher rate, but a more aggressive rate than our counterparts. But it's not all diet and nutrition, but we have some control in terms of trying to prevent recurrence, and some control.
Yeah. But even those numbers that you just quoted about 5-year survival, you know, I just read something earlier today that for Black women, it's 9% less than that. You know what I mean? Like our risk factors are higher and more aggressive, and you know, our mortality rate is higher. So I would love to think that we could prevent it. And if we can do those things, we should take those measures. On the other hand, you know, I felt like I was pretty healthy when I got sick. I was riding 20 miles a day, spin class. I was, you know, working out all the time. You know, I wasn't overweight. I was like, you know, I do eat ice cream every day. We know that. I talk about it all the time, but I was, you know, pretty healthy, and it hit me like a rock. So I don't, you know, I mean, but there are factors. And we talk about this, I always believe that mine was stress related, that partly stress induced. So I think that's, you know, that's something that we can control. You know, I say choose life. Don't, you know, put the mask on yourself first and choose life and try to get the stresses out of your life. But so Dr. Lori, tell us your story.
So my story began in 2013. I was a year and a half after having my son. I did all the things that were recommended. I managed my weight. I managed my other modifiable risk factors. And what I noticed after breastfeeding my son and moving into a year and a half after, when my son was a year and a half, that I expected my breast to go back down to nearly the same size, and one of my breasts did not. And so this is what I do for a living. So I was prepared to hear that I had breast cancer in the breast that was larger. But what they found when they looked at both my breasts is that I actually had breast cancer in both breasts. On one breast, my left breast, I had an invasive lobular, which means that it started where the milk is made. That was a receptor positive, but it was pleomorphic, and pleomorphic means that it is not the expected type of cells that you would see. They're a little bit different. And I had one lymph node on the left. And then on the right side is where I had my triple negative. My triple negative was 2 centimeters, but it hadn't gone to my lymph nodes. And ultimately, I went through chemotherapy. And so I went through 3-drug regimen of chemotherapy, having 20 cycles, ultimately went through radiation after having a bilateral mastectomy with reconstruction. Unfortunately, after my radiation, I lost my reconstructions due to infection, and ultimately decided not to do a reconstruction after that. Fast forward to 2019, and I had just come from vacation, thought I had strained my back, really wasn't thinking about having a recurrence, but I went to the emergency department because I was like, I need to sort of figure out what's going on. And at that time, I was diagnosed with metastatic breast cancer. I had metastatic disease to my bone, and I had metastatic disease to one other site. And what I found ultimately when we did our testing, we did both my gene testing and we did testing of the tumor. And what we found is that originally I had triple negative on the right side. I had ER/PR positive, HER2 negative on the left side. But when we did the recurrence and we looked at the somatic profile for that, it was triple positive. So this was yet a third type of breast cancer, and it was lobular. So it just showed that I had some cells that were dormant, and for whatever reason, they decided at that point in time to move outside of where they were sort of hiding and came into a overwhelming sort of ability to go to another site. And for me, that was my bone and my liver. And so I am someone who started out with the usual trial medications. And then I went to a second line medication. And though my disease was slow, it still kind of marched on. In about 5 months ago, I decided to do a clinical trial. The clinical trial for me is based on my being BRCA positive and being somatic positive, triple positive. And that actually is working for me. I have had 2 scans, and my last scan showed that I had a reduction of my all my tumor by 80%. So
Awesome.
doing clinical trials is scary. It's not something that many Black patients do. But for me, it worked. And I think we should probably talk about the types of clinical trials that are out there. My clinical trial is a phase 3, so it had gone through lots of testing. I knew that it was equal at least to the standard of care, and that it wasn't someone who was trying to figure out whether it worked in me or not, that they knew all of that information ahead of time. So I think that some of the things that people worry about is whether the clinical trial is somehow using you as a first line of trying to figure out whether the medication works. There are definitely those trials, but you can absolutely opt into trials that have a lot of information and that can be good for you.
How do
Can you
Black patients,
explain first line, second line for like touch like we're 5 years old?
What was that, Ricky?
Can you explain what first line means for people who don't really know what that means?
Sure. So the first line therapy is the therapy that has been tested the most, that has been approved as the standard of care, meaning there's enough data to support that this is the preferred, most effective way of treating something. Then there are agents that come along that are the second line, meaning if it doesn't work, if the first line does not work and tumors progress, there is another therapy for what we call refractory disease, or disease that's not responding to that first line therapy. And then there are others. And so, you know, you'll talk about Trodelvy and some of the other drugs, and they're approved for patients for whom the first line therapies, you know, the Red Devil, the AC, and the Taxols are not working. And so first line means the first set of drugs that we give that is the standard of care. The second line therapies can also be standard of care, but they are potentially a bit more aggressive, sometimes a little more toxic, but also just not approved as the very first line of treatment. You want to give the least toxic thing that you can think of and that we know works as the first line therapy.
Got it. I thought that meant something totally different, so thank you. I thought that meant that you had to go through several drugs before you could get to that one. But
we're not saying this different. We're not saying we're saying something that's very similar, actually.
Okay.
But it's why you have to go through different drugs to get there. It's why you can't just jump to, you know, certain agents. You have to try this one, that one, and then you can get to immunotherapy. Then you can get to some of the other drugs that are more expensive as well.
So why can't you get to the best one first?
Because the first one might be best.
Okay. Okay.
And usually the first one is less than, and I think that is a major issue. The first one is usually the best and least toxic.
Yeah.
Okay.
And so that's where you want to start.
Okay.
And you know, I absolutely can appreciate wanting to do the most aggressive thing,
Right.
because we have different goals in our life. You know, I had a 1.5-year-old kid.
Yeah.
And I want to be alive for my son, to see him graduate from high school, to see him graduate from college. So my goal was as aggressive as I need to go is
Right.
what I will do, because I want to be here.
Right.
That may not be everyone's goal. So it's important to have that discussion with your medical oncologist and your surgeon so that they are on the same page as you are. As someone who got diagnosed before the age of 50, my endpoints are different. You know, I want to actually retire. You know, I want,
right.
you know, I there are lots of things that in my life that I'd like to get to do. And so I think that we were talking earlier how sometimes all patients are kind of lumped into one group. And even in the metastatic space, not every patient is in the same place. Some people don't want to be aggressive when they're metastatic. Me, I want to be aggressive. Whatever I need to do, I want to be here. And so clinical trials are scary. But I knew that for me, I was right at the cusp. And so I had to make a decision whether clinical trials would be a part of my treatment, or was I going to move to an even more toxic regimen.
Okay.
Dr. Wilson, how do African-American women find out about clinical trials?
Oh, that's such a great question. There are several platforms. There is a platform in the at the NIH. .gov. I'm blanking on the website.
NCI. You're thinking of NCI.
Yes, clinicaltrials.gov. There's also several other organizations like the American Cancer Society, as well as additional groups that work toward having you call in, and they will help you find a trial.
So you guys,
American Society of Breast Surgeons also has Breast 360, and I think that they have some access to links for clinical trials for breast too. So the ASBRS, the American Society of Breast Surgeons, as well. Ricky, I do want to circle back to your question too, because I think that, you know, the thought process many times with starting with a less toxic therapy is that at least you have somewhere to go to try something next, you know, versus starting with the last drug that's available. And then if it fails, you have nowhere else to go. And I ask my medical oncologist this question a lot, and we go back and forth about it, because there are patients that, you know, could they get chemotherapy or should they go on an estrogen blocking pill, even though they have metastatic disease? And, you know, like Dr. Lori said, it depends on your goals and your quality of life and your, you know, the things and the reasons why you would do one over another. But they try to what we call escalate therapy, so that you have something else to try after that and something else to try next, versus going to the last stop. And then after that, where do you go?
what do you do? I hear you. I hear you. Thank you for that. But circling back to the clinical trial too, on, you know, the best resource for me on triple negative was the Triple Negative Breast Cancer Foundation. And I'll put in the chat, you know, I serve on the one in that board, and it's tmbcfoundation.org. And we actually have a portal for triple negative trials on our website. The other thing too, Marquita, is we're part of a campaign, Touch is part of a campaign called Black Data Matters. And we're partnering with the Morehouse School of Medicine and a company called Citizen with 2 I's. And basically they are if you go on our website, you can find it. But they are creating a database where they consolidate your medical records and kind of make it easier for you to access a trial. And then ultimately they will be like sort of a matching service with trials. So it's a way to, you know, make the process easier. I tried to help my friend Allison get into a trial. She's very, very brilliant, a PhD. She goes to Yale Medical Center, and it took the 2 of us 3 weeks to collect all of her stuff to get into a trial at Sloan Kettering that she was then rejected from. It was a nightmare putting all the records together and all the scans together in the way that they wanted them. So the one thing that Citizen does, that does all that for you, and you have a file of all your scans and all your records, and it's a really, really great way to do it. I'll put the link.
And I think that you make a good point. When you are going through your treatment, it is something to think about ahead of time. Every study that I had, I asked, can I have that on disc? And
Right.
So by the time I was done, even though I had my management at 3 different facilities, I actually had my disc that was my my portfolio per se,
Right.
of what my films and what my pathologies were, so that I could keep them with me. You can absolutely ask your doctor every time that something is done, can I get a copy of that report? Can I get that on disc? How do I get that done? And that's usually a very easy same day thing to do when you're thinking about it. But ultimately, bring it all together, you're absolutely right. It becomes almost overwhelming.
Overwhelming. And then you feel well.
that
You don't
day.
feel well. You know, you don't feel well. You
Yeah.
don't feel like it. So
Absolutely.
the thing now, I mean, I use my Citizen file all the time when I go to my endocrinologist, whenever I get blood work, and that, like, I just pull it up. Like, what was your latest blood work? It's all here on my phone. And so it's a great, great way to consolidate everything. That's very, very helpful. But then when you want to participate in the trial, you just click a button. You also, when you want to sign up for that, you can enroll in the Morehouse Total Cancer Care Program, which I also did. And we'll talk more about that soon. But and then just, you know, kind of put your body into science. And we need, you know, to your point, Marquita, we need to participate in clinical trials. I believe that our physiology as Black women is different, and we just don't understand it well enough. And until we do more science and do that work, you know, we're not going to be able to crack the nut on these mortality rates. So it's so important that we participate. And I know we're all afraid of it, and we have trust issues, but and I think it's like relinquishing control to science, you know, because we're all such control freak divas. But I think that we need to make sure that we do that to advance the science of our disease. So.
And just know that
And
all
when we-
trials aren't drug trials either. You know, I'm a principal investigator on a trial that is a decision-making trial. We do molecular studies on stage 0 breast cancer to tell women what their risk of recurrence might be, to help them decide whether or not they're going to do radiation or not. and they get to make the decision. It is ultimately up to them, but they're enrolled in a registry, so a trial that keeps a list of what women got tested and what decisions they made. And that's a clinical trial. And so, you know, all trials are not designed to give you something like Dr. Lori said, something less than the standard of care. And many times there are, I do an exercise trial at my institution. You know, there are lots of clinical trials that are not always drug trials. And so I think that we have to be on the lookout and be open-minded to those things, because they're a good way to get you understanding that process and help you make some good decisions too.
Yeah, right now, the participants.
Step away for just 1 minute. I'll be right back.
Yeah, so thanks, Dr. Lloyd. Yeah, Dr. Lloyd was coming out of surgery with a patient when she came on earlier, and so she's go check on her patient. No, and you know, the participation rate for Black women in clinical trials is like 3%. So let's talk about some of these new therapies, Mo, that have come out for triple negative. There's some really, really good work being done that didn't exist before, right?
Mm-hmm. Let's talk about it, because this is a vocabulary lesson, and this is something important for people who are watching to reference again, because you know, you may not remember it, or you might jot it down on a piece of paper, and then you talk to your girlfriend and she has triple negative breast cancer, and you say, what was that drug, the TR or something or other? So put a little bookmark next to this, because there's so many drugs and they work by so many mechanisms, but it's really important that they do. These drugs target different parts of a cancer cell, and that is the basis for all of this, is that cancer cells go wrong in their machinery, and the machines go haywire, and then they no longer die when they're supposed to. So there's drugs that target when they're supposed to die. There's drugs that target how they reproduce. There's drugs that target the very surface of the cells. And you know, this is, it's important for the doctors to know, but it's also important for patients, because it's why you end up with some of the side effects that you do, because of the ways the drugs work. So you got some information for us on some new drugs. This is supposed to be some good news, so let's chat about it.
Okay, and even before I start, you know, can you maybe explain what immunotherapy is? Because that's kind of the wave of a lot of the new cancer drugs, like what, and it's different from chemotherapy. Can you explain kind of that a little bit, and then I'll tell you about the drugs?
I absolutely can. So immunotherapy is, as the word implies, immune system, right? So it's a type of cancer treatment that is designed to help your immune system fight cancer. Our immune systems are made up of white blood cells and tissues in our lymphatic system, which are the drainage stations for inflammation, for infection. So like the glands in your neck when you get a cold or a flu, you know, these are the drainage sites for infection and inflammation. So if cancer is to happen in the breast cancer happens to travel through the lymphatics to the lymph nodes many times. So immunotherapies are designed to prime or assist our immune systems. And many times they have to be given with those, we call them cytotoxic agents, that red devil, the drugs that make you lose your hair and things like that, because those drugs target the fastest growing cells in the body, which is what cancer cells are. So immunotherapy is on the rise because it is designed uniquely for your immune system. They can give it to you and let your body use it to help itself. I think that's a pretty good basic explanation.
Yeah, that's awesome. Thank you. Thank you. So, so really until last year, there were no drugs for metastatic triple negative. I think Dr. put us on mute. But last year, a drug named Tecentriq was released, I believe like last March or April. And it's a great, amazing drug. And it's basically has reduced the risk of death by 38%, which is huge. It doesn't sound like a huge number, but that's a huge number. And you have to have a PDL gene mutation to take Tecentriq for it to be effective, but it is working miracles in a lot of women and doing great work. So it's called Tecentriq, and I'll put this all in the chat. It's made by Genentech, by Roche, and it's really a wonderful drug. And it was the first drug really in like 20 something, I mean years. I don't think it's really the first drug for triple negative specifically. The next one is Trodelvy, and I'll put that in the chat as well, Trodelvy, and it was just approved by the FDA a couple of months ago. And that's really for all triple negative. You don't have to have a specific gene mutation, and it's also getting great performance and great numbers. Allison, go ahead.
What's that? No, you go ahead.
No, so Allison was had taken a bunch of different drugs. She's been metastatic for about 1.5 years, and nothing was really working for her. Some was shrinking her tumor, but she was having awful side effects. And I now have my friend Allison back. She's been on it for about 6 weeks now, and she's a new person. So I swear by this drug. I think it's doing phenomenal work in triple negative. And then the last one is still in testing. That's a drug called Keytruda, which has been around for a while and been used in other cancers, but has recently been tested for triple negative with some chemotherapy. And that's showing that it's to reduce the risk of death by 35%. So those numbers still sound kind of bleak, but triple negative mortality rate is not so great. So those numbers are really, really huge. The really good thing is that Tencentric, they had a clinical trial and it was a global clinical trial. They had 7% participation by Black women globally, but in the US, they had 20%. So that's like an unknown number for us. Uh-oh. You put on mute, Lori?
I'm back.
Are you back? Back.
We're talking about targeted therapy. Sorry, Ricky, I didn't mean to cut you off, but we're talking about monoclonal antibodies, Tencentric. We're talking about Trodelvy, which is that's a topoisomerase inhibitor, and how cancer drugs target different parts of the cell and how immunotherapy works. And then you brought up Keytruda. So, Keytruda is a great drug for many things, particularly for lung cancer. It's been shown to have significant benefits. Same thing with Tencentric has been shown in non-small cell lung cancer. But Keytruda is very expensive. It's like almost $10,000 a treatment for some people, some places. And so I know our hospital has to work really hard to help patients offset the cost of these drugs. And this is why they're not all first line therapies also, because they are very, very expensive drugs to make and to administer. And it's just, it's unfortunate.
And Keytruda, the data is still very new. Like it's still new for triple negative. I don't think it's really been approved by the FDA yet, but the trial information is looking good. So, but that's also in combination with chemo. So,
and then we also have to think about clinical trials. They still bill your insurance company. And so the things that you have done have to be covered by your insurance company. And so it depends on what your coverage is, what your deductible is. I'm lucky that I have insurance that's private insurance. My husband private insurance that covers me. We learned that in the very beginning. There is not enough insurance, usually even in private insurance, for some of these very complicated treatment regimens, especially as you move along. And so we're lucky that we have double coverage so that we're comfortable. But that's not always an easy way. And so financial planning and financial discussions about it should be something that is held, but it shouldn't be prohibitive.
Right. We have so many women that don't have insurance or underinsured, and you get sick. What are you going to do? What can you do? So that, so the one of my favorite things I've learned about Kamala Harris in the past 24 hours is that her mom was a breast researcher. Yeah. Breast cancer researcher. Yep. So I'm hoping that they're going to tackle healthcare and really talk, do something to help the healthcare in our country, because it's
a great point, and I'm really hopeful. I'm going to let you get in here, Marquita, in one quick second, but I'm hopeful that we work on a repository or a place for patients to be able to go to understand what drugs are available to them at reduced rates. So as it stands, my hospital is blessed enough to have a financial navigator whose sole job it is to sit down with patients and go over where they are with their finances, what are their anticipated expenses, so they don't show up for their first day of chemotherapy and get hit with a $10,000 bill. Even though they may have insurance, and now you're trying to decide between your mortgage and your kids' insurance and your car payment or your chemo. But there are some laws that can be prohibitive there for patients to get that. Some places call it charity care. And many hospitals and institutions are requiring patients to look this information up for themselves. And then they can bring it to their doctors and they can say, oh, there's a program I'm eligible for. But if you are not feeling well, if you are recently diagnosed and you're stressed, the last thing you need to be doing is trying to figure out, how can I get a coupon for my chemo, right? Like that's not the place to be cutting coupons.
Right.
And so I think that as we talk about this and the power of our advocacy organizations, we need to advocate for this, for charity care and things to be built into the cancer programs to help patients be able to figure out their finances, because, you know, there aren't enough of those types of services available. And so patients won't even get offered some things because the docs, you know, and the hospitals know that these are beyond that patient's means.
And I think one of the things you brought up that I think is important is the accountability for some of not bringing your best self to your treatment. It is not the patient's fault that they are not feeling well. We have to continue to understand that patients will not feel well, and that mental health aspect to that also needs to be addressed.
Yeah.
That you cannot show up as your best self when you may have some elements of underlying depression, your elements of not, or even, it doesn't even have to be depression, but not feeling your best, not emotionally your best. And we don't have a lot of discussion about how that is supposed to be typically regimented in the care of patients so that everyone is getting it and everyone is being addressed.
Very true.
Yeah.
I want to let Marquita jump in here.
Yeah.
What percentage of triple negative breast tumors express the PD-L1 protein? Do we know?
I think it's about 40%. So it works
Okay.
on about 40% of triple negative breast cancers that we know of. Yeah.
Oh,
I know that one of our breasties, Shantae, who's been on the show, she actually is in a clinical trial for testing with for all triple negative, and she's taking actually the standard of care drug carboplatin, but she's definitely in a trial. So there are trials going on now to see if it can be expanded to all triple negatives.
okay.
But right now it's approved by the FDA for PD-L1, which is about 40% of triple negatives. So, and triple negative breast cancers are really about 10 to 15% of breast cancers, you guys, right?
20% of African American,
Yeah.
for the most recent, yes.
Yeah. So we always get the bad stuff, you know, black breast cancer. Here we go again, right?
Mm-hmm. 10 to 15% overall, 20% African Americans. And interestingly enough, ours is not more often associated with the BRCA mutations. Whereas, you know, I think our white counterparts, you know, their triple negative can frequently be involved with their BRCA mutations that they inherit, you know.
Right. Women of Ashkenazi Jewish descent
Mm-hmm.
have a very high number of triple negative and with BRCA. So, well, we don't. I mean, I don't have any gene mutations. So.
You know, Ricky, my mother died of ovarian cancer 29, and my grandmother had breast cancer twice, and I don't have a BRCA mutation, you know, and it's, so you got to wonder, you know, what happens and what other genes there are and what new discoveries that we will make over the next, you know, 5, 10, 20 years that will enable us to have more targeted therapies. Because the important take-home message here from this is that targeted therapies are in general less toxic. They are more expensive, they're more specialized, but it helps to limit the amount of toxicity and target the cells that need targeting, whether it is your own immune cells to keep them from causing your body harm, or boosting your immune system, or very specific cancer cells as opposed to all the fast growing cells in the body. And those targeted therapies need to be studied in us, because we tend to end up with the therapies that are not targeted. They are the more generic drugs, like, you know, traditional chemotherapies. And so go ahead, Doc.
I was about to say the clinical trial I'm on is both a targeted therapy, PARP1 inhibitor, as well as immunotherapy, which is to boost my immune system. And you know, the statistics are so low for us being a part of these trials. Yeah. It's important because we can't know if it works in us as effectively. Maybe this is something that when you use it in a predominance of Black patients, that it is overwhelmingly a very positive drug. We don't know that because we have such a difficult time. And I just want to say, and I always say this, that the number one reasons why Black people are not in clinical trials is not because of mistrust, it's because we're not asked.
Right.
Is because we're not asked to be in clinical trials for a a myriad of reasons. Once you get into clinical trials, then you have the other stereotypes about whether we'll complete trials, whether we, will show up for trials. Absolutely, I think a very antiquated look at what women bring to the table, especially Black women.
Right. I hate when they say we didn't have any Black people for the job. It's the same thing, but the other thing too is that there's also these sort of comorbidities that exclude you from a trial, like diabetes, being overweight, high blood pressure. And, those are like very prevalent in our community. I think we're like 1 in 4 Black women are going to get diabetes over their lifetime. So, we're getting ruled out or excluded from the trials because, well, why can't they make drugs with people with diabetes? Well, that's crazy.
No, they only want the healthiest of the sick, but that is essentially what it comes down to.
Right.
But you're absolutely right, Ricky, that there are a lot of different factors for why. And Dr. Laura, you bring up a good point. And the majority of cancer care is done in community centers. I practice at a community hospital. We're affiliated with Penn Medicine, but we are a standalone community hospital. And your doctors may not know of all the trials that are available because those trials aren't executed at that hospital. They
Right.
are not involved in those. And so this is where a little bit of advocacy and a little bit of research can help you, when you go with your family members to their doctor's appointments to say, are there clinical trials that I'm eligible for, that my loved one is eligible for? And if that doctor just kind of gives you the blank look, say, can you help us look that up? Is there
Right.
someone available, your nurse or whomever? Is there a trials coordinator here? Is there somebody who can help us find clinical trials? Because you should seek those out, because as we discussed a few weeks ago, they're getting more scans, they get more blood work. It is not less than, many times it is more than. And integrating that in your life can be challenging. You work a full job, you've got family, you've got obligations, and we don't make trial participation easy. And so, something has to change there as far as, one, accepting that patients are not monolithic and that they have comorbidities, and that we need to be able to include patients with those comorbidities and try to normalize for those. Maybe we have an endocrinologist who helps to manage all the blood sugars and tries to get the A1Cs under control and it's what we call confound the data. It makes it harder to understand because the patient may be sicker from something else. So you can't tell, are you in the ER because of your chemo drug or because of your blood sugar, right? I get it. But in the year of our Lord 2020, there should be a way to begin to tease out some of these factors and not just exclude patients from those trials, because it's not reflective of real life. Because in real life, that patient who's going to take that drug may have diabetes, they may have coronary artery disease, they may have asthma. And so, we have to reimagine how we look at clinical trials and start to use what we call real world data, real world evidence, how patients are doing. Let them report how they're doing. Let them find and participate in trials, and take it out of the one office visit per time paradigm that we have.
And beginning to use our influence. It is important for us to not stand up, it's important for us to stand up for the pharmaceutical companies and say that no longer should this be the case. You should be able to figure out how to design clinical trials that will accommodate me. Right. And there is enough data out there to know that it is important to have these diverse groups within clinical trials for them to be really applicable in real life. We talk about ivory tower medicine. Yes, we do a lot of things from a perspective of the best possible circumstances, but that is not the way it gets practiced in the community when things are day to day. And so we need to actually have trials that are applicable to real life. And I so would endorse what you had to say, because it's an important of how we should be able to move ahead. And my other soapbox, I just have one other soapbox to get on.
Stand on it, jump on it, go girl.
That soapbox is that when you're thinking about patients from a pharmaceutical company standpoint, the patients like me should not be the peripheral patients. If you don't know about me, I should be the central patient you're trying to get. I should be the person that you are trying to invest more in, not just saying, oh, well, you know, why can't you join? Because you should just be like everybody else. I'm not like everybody else. And you should think about me before you think about putting together your trial and adding all the things that I need to be my best self for your trial. So
Right.
that's my soapbox.
There's your
That's
soapbox.
a
And you know,
huge soapbox, and I need you to stand on that soapbox
I know,
every chance
Brandon.
you get, because as we get, you know, invited to the table more and more to have these conversations with pharma, to, you know, Tiger Lily's got a wonderful inclusion pledge that is encouraging people to, you know, pull up, make room at these tables, not just for the trial enrollment, but in the trial inception even, you know, and have these conversations early. That's a huge part of it. I want to extrapolate a little bit to talk about the coronavirus.
Before you go on, can I say one more thing on that?
And yeah.
Life is not a petri dish.
Mm-mm.
You know what I mean? And I think
Sure
they're
isn't.
scientists. And so tomorrow I'm actually have an opportunity to speak to a group of 1,000 clinical trial practitioners at one of the bigger pharma companies that we work with. I'm so excited. So you're giving me my talking point. So thank you for that.
Yeah, you're welcome.
But
Absolutely.
it's really not a petri dish. We live and we, you know, we breathe and we're people. And you know, we kind of are the social determinants of health when you think about Black women.
Yes.
But
Mhm.
but those need to be addressed. We need to be addressed, and we shouldn't be excluded for who we are, because this is who we are. So.
And you know, I just want to say, because I know we're going to get ready to wrap up soon, but for people who are watching, you know, we started this because of the coronavirus, because we're in the middle of a pandemic and our breasties can't meet in person to have support groups and have opportunities to get some of this information. And we wanted to bring it to your living room. But as we talk about clinical trials, keep in mind that our people continue to be the most vulnerable. We continue to be the most affected. And if you're going to change your mind about clinical trials for cancer, change it about everything else, because we need to figure out what works for our communities, and we can play a role in that by being active in clinical trials. If you are approached about a trial for the coronavirus, for other things, you get the information, weigh it, talk it over with some advocates. You know, you can contact Touch, you can contact Ricky, you can contact me. You got people. It's like the mafia. You got folks.
Right.
And we need to pull up for each other and for our community, because it's not just cancer that's affecting us. That's my soapbox.
I am so there with you. Absolutely.
Yeah, no, we have to change the paradigm on this. We really do. I mean, you know, and it's funny because I've been thinking a lot, but like, you know, what do I really want to do? I want breast cancer mortality rate parity. So what does that mean? We probably can't cure breast cancer in my lifetime, but at least my mortality rate should be at parity with white women.
Yes.
It shouldn't be 42% higher, right? So that's what we all have to work towards. So.
Well, I would like to add one thing from a patient standpoint. For triple negative, I'm not encouraged that a lot would change until we start to look at the different subtypes, because the subtypes respond different treatments.
Right.
The research is for metastatic breast cancer.
Right.
And I looked at a lot of the research on clinical trial, and most of it, like 80%, was for metastatic.
Right.
So until the research addresses
clinical trials out there that aren't metastatic. It is
I said the majority.
No, I'm saying the majority aren't metastatic. The majority of clinical trials are for non-metastatic patients.
For triple negative?
I'm talking about
for triple negative, maybe, or I'm sorry, we
the different subtypes of triple negative. I don't know if I'm just not encouraged personally that we're going to make a lot of headway, but that 20% of women who get the recurrence after having the standard treatment, because we know with the standard treatment, 20% of women do recur within the 2 to 3 years. That's been going on forever. And, you know, just from a patient standpoint, I think more needs to be done in the subtype arena in order to address the different subtypes.
Yeah, we'll look that up. But yeah, and actually the overall recurrence rate for Black breast cancer is 39%. I don't know what the number is for triple negative, but we'll look that up, because I also agree too. Like, you know, I had stage 3A triple negative and there weren't any drugs for me. And why wait till I'm metastatic to get a drug for me, you know?
Right.
So
There are more and more trials for early stage, before it becomes metastatic, but you're right. Traditionally, there have been more trials for metastatic than for early stage triple negative breast cancer. And it's an area that, we are starting to see some improvements in, but we have a long way to go, Marquita. You're right. Mhm.
Okay.
I don't want anybody to die.
I agree.
I agree with you, Ricky, and I am, I don't want to see parity. I want to see us live, I don't want equal death rates. I want more survival.
More life, more life.
Yep, more life.
More birthdays,
Absolutely.
more weddings, more boyfriends.
And more joy, more quality of life, better mental health, better sleep. I want us eating good food and getting good rest and drinking water and not being afraid to walk our streets. We got a long way to go. So I'm encouraged by what's happening in this country, hopefully with respect to, elections and things like that. And I want to encourage people to just stay involved, stay engaged in the process.
Yeah.
Because, this is 2020 and sometimes it feels like 1965, but there are some real opportunities for change that can happen at every single level. I mean, who would have thought, these survivors and Black doctors would be on this program reaching 40,000 viewers, and there's an opportunity for you to have a role in advocacy, for you to have a role in clinical trials and research, for you to have a role in just, being a support system for your loved one with breast cancer. So don't check out. I know things are a little bit depressing right now and everybody's tired of what's happening right now. We all have fatigue from watching people on the screen who shall remain nameless, but don't check out. It's time to dig in.
Call me. I will put you to work. If you want to work in advocacy, just email me. I'll put my email. Terry, put my email in the chat because we have much work to do.
Hashtag much work to do.
Much work to do. We'll give you.
Dr. Lori, how can people find you if they need a great doctor, if they want to see you for a consult, if they want to talk to you, encourage you, if they want to transfer their care, if they want to see you, where can they find you?
That's wonderful, wonderful question. I'm at Howard University Hospital in Washington, D.C.
Yeah.
And I am at lori.wilson, lori.wilson@howard.edu. Happy to talk to anyone, text me, call me, let me know what your needs are. I am happy to talk you through it. I'm happy to support you through it. My mantra is really more about getting the perfect care for you than having the care by me, because it is about centrally the patient. And it is important for the patient to have the right rapport and the right team. And that doesn't have to be me, but I can help do amazing things to get that team for you.
I love that. I love it so much.
Love you so much.
Marquita, how can people find you? How can they get the book? Do you have a copy? Can we see what the cover looks like? There it is. All right.
The new pink, My Battle with Triple Negative Breast Cancer. You can actually download from Kindle on Amazon or get a copy from Amazon. Also go to marquitabass.com if you want a signed copy of the book. If you reach me as a patient, email me at marquita@marquitabass.com. I'm not a doctor, I don't give medical advice, but I will share experience. And just email me, marquita@marquitabass.com. Thank you.
Thank you. I'm Dr. Monique Gary on all social media outlets, on the Facebook, the LinkedIn, the Twitter, the YouTube, the Instagram, all that. and if you need me, I'm very responsive because this work is important. This is our life's work. This is our heart's work. And we want to see our breasties thrive and survive, and we want to do everything we can to support that and to advance the health and wealth of our community. So please feel free to follow me on social media and reach out if you need something.
Yeah, and I'm Ricky at Ricky Dove, or our social media is at Touch BBCA, Touch the Black Breast Cancer Alliance on Instagram, Twitter, and Facebook. And email us, call us, put in the comments. We'll find you. Call me if you want to work in advocacy and
volunteer. Yeah,
we just need some breasty love, and I love you guys so much.
Thank you. We hope this has been relatable, reliable, and real. The doctor is in. Dr. Wilson, you are welcome anytime you want to come on. Every Wednesday at 6, we're here. So you come join us. We got more soapboxes for you to stand on.
I think you're on mute. You're on mute. Yeah, breast.
I said, I'll be here all the time. Don't even say that.
Come on
We
over.
love it. You're welcome.
Rescue
Thank you
love.
so much.
Rescue love. Thank you so much.
Thank
See you next week.
See you next week. Bye.
Bye-bye.
Thank you.
Thanks for having me.
Thank you.